I am Kelly Thrush and am a graduate student in the Doctor of Nursing Practice Leadership program at Penn State University. Depression represents a significant health challenge in older adults, and according to the Centers for Disease Control and Prevention, 15.5% of adults 65 and older have depression in the United States. Depression affects older adults and has negative consequences on their quality of life. We all have parents, aunts, and uncles, and other friends that are close to us within this age group. We want them to have a full life enjoying their family and hobbies. They are special people in our lives that have taught us so much, loved us, and contributed to our family's lives. But when our loved one ends up in the hospital repeatedly, or declines physically or cognitively, you and they may realize the need for more assistance. Whether they want to admit it or not, older adults have many challenges when they lose their independence. This map gives you a visual of the prevalence of depression for adults 65 years and older in the United States, with the light blue representing prevalence of depression at 12.9% or below, and the darkest color representing 17.4% or higher. This graph shows the prevalence of depression for adults age 65 and older between the years 2011 through 2022. As you can see, not much progress has been made in reducing the prevalence of depression over the years. This is concerning as the older adult population will continue to increase. According to the U.S. Census Bureau, the U.S. population age 65 and over is projected to nearly double from 2012's population of 43.1 million to 83.7 million by 2050. That's in about 25 more years. Most of this growth is occurring now within the years 2010 through 2030, as baby boomers reach age 65. Of note, older adults age 85 and over is the fastest growing segment of the total population, and by 2050, 4.5% of the U.S. population will be aged 85 and over. I currently practice in a long-term care facility as part of the post-acute care team. The majority of the residents are within the age group of 65 years and older. I am passionate about improving the quality of life for older adults, and I want to create a community of healthy living, safety, and engagement by providing compassionate and person-centered care. Depression is very common in people above 65 years living in long-term care facilities. Kramer et al. In 2009 showed that around 30% of nursing home residents have acute depression. This is almost double the percentage of older adults throughout the United States, as we looked at earlier, of 15.5%. Depression occurs more often in those adults whose physical capacity is steadily declining and for those who are increasingly unable to participate in activities of daily living. With risk factors for late life depression, including frailty, multiple morbidities, polypharmacy, and significant life events with old age, such as loss of independence or a loss of a spouse, also stroke, cancer, loneliness, and chronic pain, it is the responsibility of the healthcare team in these long-term care facilities to support these older adults and protect their mental health. Depression can be improved and treated with proper interventions, but depression often goes unrecognized and untreated. The PICO question guiding my literature search is, in long-term care residents, how does routine patient health questionnaire depression screening compared to usual care affect residents' functional status within a 3-month period? Keywords of the PICO question are seen here. Long-term care residents represents population, PHQ-9 is the intervention, usual care is the comparison, and functional status is the outcome. My literature search was conducted in PubMed. This allows me to search Medline, and Medline is the National Library of Medicine's premier database, and it covers articles on biomedical research, medicine, gerontology, healthcare, planning and administration, and the International Nursing Index, as well as public health and physiology. PubMed coverage is worldwide and updated weekly. Limiters I included in my search were language, as I only wanted studies that I was able to read. Also, as my population is for older adults, I limited my age range to 65 and older. Additionally, I only wanted studies on humans, and I also did not want any literature reviews, metasynthesis, or meta-analysis, and excluded those under the limiters. When conducting my search with keywords and their synonyms, I found 330,303 articles that included my population keyword of long-term care residents and the synonyms nursing home or skilled nursing. I then searched my intervention keyword and its synonyms of depression screening or PHQ or depression and found 187,133 articles. Lastly, I searched mobility or engagement or quality of life, finding over 1 million articles. I then combined all three individual searches and found 1,778 articles. By adding the limiter of 65 years and older for age, my results narrowed down to 743 articles, and then adding another limiter of articles published within the last 5 years, the results were 195 articles. I reviewed key findings of 5 articles related to the PICO question. Again, the PICO question is, in long-term care residents, how does routine patient health questionnaire depression screening compared to usual care affect residents' functional status within a 3-month period? The primary authors are listed here. A similarity for the articles was that they all used the PHQ-9, which stands for Patient Health Questionnaire 9. The PHQ-9 is a short 9-question survey and is a reliable and well-validated tool for measuring depression and its treatment outcomes. I know this is small, but what I want to point out and highlight is the fact that it is very simple and any team member at a long-term care facility can assist a resident in completing it, or a resident can complete it on their own. It can be completed and scored quickly, making it very practical. All 5 articles use the PHQ-9. This is related to my PICO question, as the PHQ-9 is the intervention being studied. Hellmark et al. Used the PHQ-9 as screening for depression in cardiac rehab, while Fawn et al. Used the PHQ-9 with patients receiving cancer treatment. Additionally, Sikonoffi et al. Used the PHQ-9 to screen for depression in different post-acute care settings, including home health and rehab centers, such as long-term care hospitals and skilled nursing facilities. And Mirtvet et al. Used the PHQ-9 to monitor and assess for depression in mental health clinics. Differences in the articles are the settings the PHQ-9 was used. Settings that were examined in the evidence include post-acute care settings such as cardiac rehab and home health and rehab centers. The other setting that the PHQ-9 were completed in include clinics. For example, it was used in primary care clinics, cancer clinics, and mental health clinics. Another difference of the articles is the purpose the PHQ-9 was used. 3 studies used the PHQ-9 as a screening tool. This was done in cardiac rehabs, cancer clinics, and post-acute care facilities. Alternatively, 2 studies used the PHQ-9 to monitor treatment effectiveness. This evidence can be applied to clinical practice in several ways. Of all the post-acute care settings, depressive symptoms are greater in the long-term care setting. It is important to implement systemic routine screening for all long-term care residents to prevent health inequities, and so depression does not go unrecognized. This will ensure individuals receive the PHQ-9 screening regardless of their risk factors. Additionally, the PHQ-9 should be used at regular intervals to catch any new depressive symptoms that have occurred since an initial screening. Changes in medical conditions, severity of pain, and mobility occur from day to day and week to week for residents in long-term care facilities. Therefore, the PHQ-9 should be repeated routinely. Lastly, prompt mental health care and close follow-up improves well-being and was found effective in remission of depression even after 12 months. Key findings from these articles are that the PHQ-9 was used for screening and monitoring the treatment response of depression. Settings varied from outpatient clinics to various post-acute care settings. It was found that prompt mental health care and routine screening improved the diagnosis and treatment of depression, resulting in improved quality of life. Additionally, individuals with pain and those who are in the midst of an acute illness were found to have high prevalence of depression. Ultimately, the PHQ-9 should be implemented on a routine basis and used for follow-up monitoring of all residents in the long-term care setting, regardless of their risk factors. This will avoid any missed opportunities in recognizing depressive symptoms and prevent depression from going undiagnosed. Quality of life for a long-term care resident will improve by implementing the PHQ-9 and routine screening in long-term care facilities. Thank you for your time.